Welcome to the deep dive. We are here to take the most essential, complex clinical material and, well, turn it into actionable, memorable knowledge. Today, we are diving deep into a single term that really hides a universe of disease, the ulcer.
It's such a classic challenge in medicine, isn't it? I mean, if I ask you what's an ulcer, what first jumps to mind for most
Oh,
people?
for sure. You think a wound, maybe a bad infection, or you immediately jump to the scary stuff like cancer or just chronic, unending pain.
Exactly. But the source material we're leaning on today, and it's a fantastic, really structured approach from experts like Dr. Senthil Kumar and K at IM's Nagpur, it shows us that the word ulcer is just an umbrella. Underneath it, you've got venous stasis, arterial failure, neurological destruction, even aggressive malignancy.
And you can't just treat the hole in the skin. You have to know the systemic disease that actually caused it. So our mission today is really a shortcut to mastering that clinical approach. We're focusing on a theme that guides every great practitioner. See, feel, think, then diagnose.
And that's it. It's about transforming yourself from someone who just sees a wound into a medical detective who can read a biological story.
I like that. So where do we start? The definition, I assume.
We have to start there. The precise definition is the foundation, because this is what separates an ulcer from, say, a simple cut or a scrape. An ulcer is defined as a breach in the continuity of the surface epithelium, so the skin or a mucous membrane that has, and this is the critical part, failed to heal.
So it's the failure of the repair process that really defines it. It's a chronic problem.
That's the key. It demands you investigate the deeper underlying cause.
And the visual diversity is just, it's astounding. I mean, the sources we have, they emphasize this by showing photos. You compare a pale, punched out arterial ulcer to this wide, sloping, pigmented venous ulcer. You can see immediately that these are completely different things, even if they share the same name.
The diagnosis is literally written on the patient's body. You just have to know how to read the signs.
And that's the whole point of this deep dive for you, the learner.
Yes. It's about synthesis. Ulcers are the outward signs of major systemic failures. It could be vascular plumbing problems, chronic nerve damage, or a prolonged inflammatory cascade that leads to cellular mutation. We're going to give you the framework that clinicians use to turn these confusing local symptoms into a coherent, evidence-based diagnostic story.
Okay, so let's unpack this clinical journey. Let's start at that crucial first step, taking the patient's history. This is where we learn the narrative, the story behind the wound. The sources provide a clinical memory tool that is just absolute gold, a comprehensive checklist they call the mnemonic shortcut. Old carts plus 3 Ps.
This mnemonic it's just indispensable, really, and make sure you don't miss a single critical piece of data. And in the context of an ulcer, the story the patient tells you, it often gives you the definitive answer, or at least it narrows your differential diagnosis down to maybe 2 possibilities before you even lay a hand on them.
It's that powerful. Okay, let's deconstruct old carts. We'll start with O for onset. So was it spontaneous or did something happen first, like a minor trauma?
And that mechanism is everything. I mean, if a patient says, I stubbed my toe 3 months ago and the wound just never closed, that immediately suggests a failure of healing. Your mind should jump to systemic factors, like poor circulation or diabetes, that are preventing the response to that initial trauma.
And if it's spontaneous?
A completely different story. If an ulcer just appears, maybe after an infection or a systemic fever, that points you toward an immunological or even a malignant origin.
Got it. Okay, the second letter, L for location. You said this is arguably the biggest shortcut in the whole process. The site just screams the diagnosis.
It truly does. The body is highly organized, you see. So if you see an ulcer in the gaiter area, that's the lower third of the leg, above the ankle, below the calf, your mind should immediately lock onto venous causes. It's all about the hydrostatic pressure in that region.
Okay, what about other spots?
Well, if the ulcer is on the very tips of the toes, or maybe the lateral malleolus, that's the outer ankle bone, you must immediately think arterial disease. Those are the furthest points from the heart. They're the most prone to critical ischemia.
And on the sole of the foot.
That's pressure and nerve damage, a trophic or a neurogenic cause. So you see, knowing the location gives you, I'd say, 80% of your initial working diagnosis right there.
That's incredible. Okay, next is D for duration. Days, weeks, or months. Why is the time frame so critical here?
Duration determines chronicity, and chronicity is linked to risk. An ulcer that's been there for a few weeks, it could be a standard infection. But an ulcer that's been there for 6, 12, 18 months, and it's defying all treatments. That raises 2 huge red flags.
Okay, what are I?
First, it confirms a severe unaddressed systemic issue, like uncontrolled diabetes or critically low perfusion. And second, maybe more alarmingly, The sources really emphasize the risk of malignant transformation, the famous Marjolin's ulcer, which develops in chronic, non-healing scars and inflammation. So long duration demands a biopsy, period.
Right. Then we get to C for character, and the focus here is heavily on pain. We've heard that the pain level is the ultimate differentiator.
It is the clinical hallmark. We'll dive deeper into this later, but you have to remember the spectrum. On one end, you have this excruciating severe pain. That's the arterial ulcer. The tissue is alive, but it is screaming from profound oxygen deprivation. It's a truly agonizing ischemic rest pain.
And on the other end of the spectrum.
The other end, you have the notoriously painless trophic or neurogenic ulcers. The reason they exist is because of the nerve damage, so the patient literally cannot feel the wound developing or getting worse. If you miss that detail, that pain characteristic, you are already on the wrong diagnostic path.
That distinction to tissue suffering versus tissue death is just fascinating. Okay, moving on. A is for associated symptoms. So what else is going on with the limb or the body?
Right, we look for systemic indicators. Is there a fever, chills, widespread malaise? That suggests an active systemic infection, maybe bacteremia coming from the wound. What about profound limb swelling, edema? That strongly supports a venous or even a cardiac cause.
And things like skin color.
Absolutely. Discoloration or pigmentation around the wound points directly to chronic venous insufficiency. That's where blood products leak out of the compromised veins and literally stain the skin. These symptoms link the local ulcer to the body's overall physiological state.
Okay, next up is R for relieving or worsening factors. This is where the patient gives you insight into the mechanics of their own circulatory system.
Exactly. This is just pure applied physiology. You ask the patient, does putting your leg up help? If elevating the limb relieves that discomfort or aching, because it's improving venous return and reducing hydrostatic pressure, you're almost certainly looking at a classic venous ulcer.
And the opposite for arterial.
The complete opposite. If the pain is so severe they can't sleep and they have to hang their foot off the bed to get any relief, that's the so-called dependent rubor. That is the signature move of severe arterial ischemia. Lowering the foot uses gravity to pull what little blood is left down there, and that slightly eases these ischemic pain.
Wow. Okay, and we finished the CARTS part with T for treatment taken and S for similar lesions before.
Right. Reviewing the treatment history tells you what doesn't work. If they've tried topical antibiotics, standard dressings, and yet the wound is getting larger, it confirms that local management is irrelevant. The primary systemic driver, be it diabetes, poor circulation, or an aggressive infection, hasn't been addressed.
And a history of similar lesions.
That suggests a chronic recurring pathology, like recurrent venous thrombosis or poorly controlled diabetes that just leads to cycle after cycle of trauma.
Okay, so that's oldie CARTS. Now we move to the essential follow-up questions, the 3 Ps. You said these turn the raw data into a full clinical profile.
They do. The first P is just a specific follow-up on pain. Don't just accept, yes, it hurts. You need the quality. Is it a dull ache? That's characteristic of venous congestion. Is it a sharp, burning, electrical pain? That might suggest nerve involvement, neuropathy, or is it that severe cramping pain that wakes them at night, the claudication and rest pain of arterial disease? The nuance matters a lot.
Makes sense. The second P is progress. Has it grown, shrunk, or just stayed the same?
And failure to progress is just as significant as rapid growth. An ulcer that hasn't changed size or character in a month, that's a problem. Rapid, uncontrolled growth, especially with tissue hardening, screams malignancy or a highly aggressive infection. Stasis, on the other hand, suggests a profound block to healing, whether that's immunosuppression or just persistent pressure.
And the final critical P is past illness. This is the great connector, right? Linking the local wound to the patient's entire medical history.
This is the one you cannot skip. The source material lists the necessary conditions to ask about: diabetes mellitus, DM, varicose veins, previous radiation, even historical infections like leprosy or syphilis. If a patient is a long-term smoker with hypertension and DM, you are immediately thinking trophic, arterial, or a mix of both.
Or if they have a history of DVT.
If they have a documented history of a severe deep vein thrombosis, a venous ulcer is almost a foregone conclusion. This step prevents the error of treating the symptom while ignoring the disease. It's the difference between temporarily bandaging a leak and actually fixing the burst pipe.
So this entire history phase is about becoming that detective, understanding that the wound is just the punctuation mark at the end of a long, complex story of physiological failure.
Precisely. You're building a narrative that your physical exam will either confirm or deny. And a well-taken history is safe, it's cheap, and it's non-invasive. It's the highest yield diagnostic tool you have.
Okay, we've gathered the story. Now we move to the physical confirmation, the see and feel phase. So section 2 is about transforming simple observation into structured clinical data.
An inspection requires incredible discipline. We're moving beyond just the general look of the limb to really dissecting the ulcer into its components. We start simple. Site and number. Is it a single ulcer or are there multiple? Multiple ulcers often suggest something systemic, like a vasculitis or an infection that's tracked along the lymphatics.
Then we get into the 5 key architectural components of the ulcer itself. The edge, the margin, the floor, the base, and the discharge. That sounds like a lot.
It is, but let's break it down. Let's start with the visual difference between the edge and the margin. The edge is that critical boundary where the ulcerated tissue meets the surrounding skin. This is the single most important diagnostic feature, which we'll drill into in section 3. The margin is the skin around the edge.
So what are we looking for in the margin?
Is it pigmented? That brown staining suggests hemocysteine deposition from chronic venous stasis. Is it red and inflamed? Erythematosis? That suggests an active infection. Is it white and shiny? A trophic? That suggests chronic ischemia.
I see. So the edge tells you what the process is doing to the skin, and the margin tells you what the underlying disease has done to the surrounding tissue.
That's an excellent way to conceptualize it. Perfect. Next, the floor. That's the visible surface of the ulcer. Is it covered in healthy, bright red, bumpy granulation tissue?
Which means it's trying to heal.
It's trying to heal, exactly. Or is it covered in pale, dull granulation tissue? That might signal poor blood flow, which you see in tuberculosis or profound ischemia. Or is it covered in slow, that grayish, fibrinous, dead tissue?
And what about the base? I'll admit, I always confuse the base with the floor.
Common mistake. The floor is what you see. The base is what you feel. The base is the underlying structure of the ulcer, the tissue that supports the floor, like muscle or tendon or even bone. Palpating the base helps determine its fixation and induration, which is our next step.
Okay, and lastly, the discharge.
Right. What's coming out of it? Is it thick, creamy, and purulent? Bacterial infection? Or is it pale, watery, and serious? That suggests less aggressive inflammation or maybe just venous drainage. The color and consistency are diagnostic.
So once inspection is complete, we move to palpation, the hands-on data. We're confirming or rejecting our visual hypotheses with touch.
First, we check for tenderness and temperature. Tenderness confirms the tissue is viable, but it's suffering. Think of that painful arterial ulcer. Temperature is a critical proxy for blood flow. A pale, cold limb suggests profound arterial ischemia. The body just can't circulate enough warm blood. A hot red limb suggests massive inflammation and infection.
Then comes induration. How do we describe this hardening of the tissue around the ulcer, and why is it so significant?
Induration is that palpable thickening and hardening of the subcutaneous tissue around the ulcer. It's caused by chronic inflammation leading to fibrosis. Clinically, you pinch the tissue surrounding the wound. If it feels hard and rigid, like old leather, that's induration. It's critical because it points toward a chronic, resistant condition.
And in the worst case?
Critically, a rock-hard, fixed induration in the base of a long-standing ulcer is highly suspicious for a malignancy, like Marjolin's ulcer. It means cancer cells are invading deep into the underlying fascia and muscle.
I can see how easy it would be to miss that if you didn't physically feel the base. But the source material stresses that the most revealing piece of data found only through touch is the sensation check.
This is a non-negotiable step, especially in patients with diabetes or suspicion of leprosy. You have to check the patient's sensation using light touch or a pinprick around the ulcer. Loss of sensation anesthesia is the absolute defining feature of the neurogenic or trophic ulcer.
So if the patient has a deep infected ulcer but reports no pain and can't feel you touching it,
The entire diagnostic pathway shifts instantly. You stop focusing on vascular repair and you start focusing on pressure relief and diabetes control. If you miss this step, you treat the wound, but the patient immediately re-injures the foot because they don't have that protective feedback of pain.
that makes perfect sense. The sensation loss is both the cause and the defining feature. Finally, we look regionally.
We palpate the regional lymph nodes, the ones that drain the ulcers area, enlarged, soft, and tender nodes. That suggests the body's actively fighting off a local bacterial infection. Conversely, enlarged, hard, and fixed nodes, especially in the groin if the ulcer's on the leg, raise the profound alarm of systemic spread of a potential malignancy.
And we can't forget the simple but essential step of measurement.
No. Every ulcer needs baseline data: length, breadth, and depth. It needs to be documented precisely. If you look at an ulcer a week later and the size hasn't changed, the treatment is fundamentally failing. The sources are clear. Failure of an ulcer to show any reduction in size after 4 to 6 weeks of appropriate targeted management is a strong indication for immediate escalation. You biopsy, you investigate deeper. Measurement is the clinical yardstick of success.
All right, so we've collected the history, we've done the detailed physical exam. Now for the final step in the see, feel, think method, synthesis and classification. Section 3 is all about mastering what the source material calls the diagnostic matrix. Know the edge, know the cause. We're focusing on 4 key comparative parameters: site, pain, edge, and base.
This is really the centerpiece of the discussion. This is where all the observations come together. The structure of the ulcer, particularly that edge, it so often reveals the underlying process. Let's start the comparative analysis with the basic one, the traumatic ulcer.
Okay, traumatic ulcers. These seem pretty straightforward. They're irregular in shape, typically painful, and their base is usually healthy granulating tissue, so the body wants to heal.
It does. The reason they become chronic is often persistent, low-level trauma or a secondary infection that just keeps setting back the healing process.
Got it. Now for the 2 big vascular categories, let's compare them, focusing on the edge. First up, the venous ulcer.
Okay. Location, as we said, is that classic gaiter area, the lower third of the leg. The pain is usually mild, more of a manageable ache that gets worse with standing. Associated signs are key: chronic edema, that brown pigmentation, and visible varicose veins. And the defining edge is sloping.
Why does chronic venous hypertension create a sloping edge? What's the mechanism there?
That's a crucial question. The sloping edge is a result of the pathology being relatively non-aggressive but very, very chronic. Venous hypertension causes this long-term, low-grade inflammation and massive edema. As the skin breaks down slowly, the body tries to repair it continuously by laying down fibrous tissue around the margins. This chronic inflammation and fibrosis create a gradual slope from the healthy skin down into the ulcer bed. There's no sharp boundary. It's a slow, drawn-out battle.
Okay, now contrast that with the arterial ulcer. These are at the toes or the outer ankle. They're associated with a cold, pale limb and weak pulses. The pain is severe, often the worst pain a patient can experience. And the edge is dramatically different. It's punched out.
That punched-out edge is an absolute hallmark of critical ischemia. I want you to imagine someone taking a cookie cutter and pressing it sharply right through the skin and subcutaneous tissue. Why is it so sharp? Because there is no low-grade inflammatory fight happening like in the venous ulcer. The blood supply is so poor that the tissue simply dies cleanly right up to the line where perfusion ends. There's no attempt at repair, no chronofibrosis, just acute localized necrosis. And the base is also pale, dry, or necrotic because there just isn't enough oxygen to support bright, healthy granulation.
I find that contrast between the gradual, sloping, low oxygen battle of the venous ulcer and the sharp, clean, critical death line of the arterial ulcer, it's a brilliant visualization.
It simplifies the distinction. Next, the trophic or neurogenic ulcer. This is found at pressure points, especially the sole of the foot or the metatarsal heads. The defining feature, which links back to our sensation check, is that they are painless.
And their edge is also often described as punched out, similar to the arterial ulcer. Why the similarity in appearance when the cause is nerve damage, not circulation?
It's related to the mechanism of injury. These ulcers develop from repeated, unfelt trauma and pressure. Because that pressure is so sustained and localized, it causes a sharp, deep necrosis right over a bony prominence. The tissue just breaks down rapidly and deeply. They tend to be deep, often involving tendons or even bone osteomyelitis, and the base is often necrotic or covered in thick, infected slough. The depth is often the key differentiator here from a purely arterial ulcer.
Okay, let's touch on the infectious causes, the tuberculous ulcer.
These are rarer. You'll often see them on the neck or chest wall in areas of lymphatic drainage. The signature feature here is the undermined edge and these pale, indolent granulations in the base. Undermined means the skin margin actually seems to overhang the ulcer base. It creates a pocket or a lip underneath. This happens because the infection, the tuberculosis, tracks laterally beneath the skin, destroying the subcutaneous tissue faster than the surface epithelium breaks down.
And finally, the 2 scary ones, the infectious syphilitic ulcer and the malignant Marjolins ulcer.
Syphilitic ulcers, when you see them, are typically punched out and feature a very specific type of base called a wash leather slough. To visualize that for you, it's a tough yellow-gray membrane covering the base. It's often described as resembling damp, chamois leather. That's the classic description of the necrotic gumma tissue.
But the one that demands the most vigilance is the malignant ulcer, or Marjolin's ulcer. This is malignancy that arises from chronic inflammation.
This is a devastating diagnosis. It usually develops years, sometimes decades, after the initial trauma like a burn scar or a chronic venous ulcer that just never closed. The signature feature, the alarm bell, is the everted or rolled edge.
Everted, so rolling outward. Why does malignancy cause that specific type of edge?
It's all about the rapid, uncontrolled proliferation of the tumor cells. Unlike benign tissue that tries to heal inward, the aggressive squamous cell carcinoma cells are multiplying so quickly that they literally push the tissue up and out. This creates a hard, firm, rolled-over border. The base of the malignant ulcer is also often friable, meaning it bleeds very easily on just a gentle touch, almost like wet tissue paper falling apart, because the fragile tumor vasculature is so poorly formed. If you see an everted edge on an ulcer that's been around for 10 years, you skip all other tests and go straight to a deep biopsy.
So this classification system brings us right to the source's clinical trick, the rapid diagnosis based purely on the edge. This is the art of observation refined down to 4 specific looks.
It's the highest yield diagnostic trick you can learn. If you see a sloping edge, you think healing, or, most commonly, a chronic venous ulcer.
A punched-out edge puts you squarely in the territory of severe pathology, trophic, arterial, or syphilitic ulcers.
An undermined edge is almost pathognomonic. It's almost a sure sign for infection tracking laterally. That primarily means a tuberculous ulcer, or sometimes a chronic sinus.
And the dreaded everted edge must immediately trigger the suspicion of malignancy. Knowing the edge can let you differentiate a manageable chronic issue from a life-threatening one in seconds.
The sources included those great conceptual triggers to really lock this knowledge down. For instance, the question, why are trophic ulcers painless? And the answer isn't just nerve damage. The answer is that the underlying condition, usually diabetes, causes a distal symmetric neuropathy. It destroys the sensory nerve fibers and removes that protective feedback mechanism that tells the body it's being damaged.
And we learned that venous ulcers heal better with elevation because you're mechanically assisting the venous system, reducing the hydrostatic pressure that causes that inflammatory breakdown in the first place. It's just simple physics.
And the final trigger, the significance of Marjolaine's ulcer. It's the profound reminder that chronic inflammation is not benign. It represents a persistent state of cellular stress that increases the risk of genetic mutation and malignant transformation. It's why chronic wounds must be monitored, and if they defy healing, biopsied aggressively.
Okay, this is where we tackle the concept that separates the acute from the irreversible. Section 4 moves us from simply classifying the cause to classifying the severity of the damage along the ischemic continuum. This is all about the crucial difference between an ulcer and true gangrene.
And this distinction is not academic. It dictates triage, it dictates intervention, and often the fate of the limb itself. The source material frames this fundamental difference beautifully and simply. Ulcer equals partial ischemia. Gangrene equals total ischemia.
That is a clean, definitive line. So an arterial ulcer is tissue that is alive but critically starved of oxygen. Gangrene is tissue that has suffered irreversible cellular death necrosis due to a complete, sustained lack of blood flow.
To make that abstract concept tangible for you, let's use the source's river system analogy. Think of the limb's blood supply as a river. If you have an ulcer, it's like the stream is drying up in patches. The water flow, the perfusion is low, causing localized tissue loss, but the system is still marginally operating. If you have gangrene, the riverbed itself has turned completely to dust. The tissue is dead, desiccated, or rotting. There is no path back for that cellular structure.
So let's break down the comparison, focusing on how a severe arterial ulcer can progress into PVD-related gangrene.
Okay, so in terms of pathophysiology and extent, the arterial ulcer is caused by severe partial obstruction. It's localized, usually just involving the skin and subcutaneous layer. Gangrene, on the other hand, requires complete arterial occlusion, a blockage so total and sustained that the tissue dies across its full thickness. We're talking skin, muscle, sometimes bone, turning black and mummifying.
The visual difference is obvious. The ulcer has that pale base and a punched-out edge. Gangrene is defined by its necrotic appearance. Jet black, maybe mummified, that's dry gangrene, or swollen black and weeping, which is wet gangrene.
And this brings us back to the most important clinical differentiator, the pain profile. The arterial ulcer causes severe pain. The tissue is alive, it's highly innervated, and it's suffering profoundly from lack of oxygen. It's demanding blood, and that demand registers as excruciating rest pain.
Wait, okay, if the tissue is dead and gangrene, why do patients with critical ischemia often report severe rest pain before the tissue turns fully black? How do we differentiate that early warning from the ulcer pain?
That's a critical question for triage. That rest pain is the body's final warning. It means perfusion is just barely above the level of total necrosis. When that rest pain is present, it indicates the tissue is still alive, still viable, and therefore it's still an arterial ulcer or a pre-ulcerative stage. It means it is salvageable. The moment the ischemia becomes complete, sustained, and irreversible, the moment the nerve endings die completely, the pain becomes absent. This is the paradox. The dead tissue stops suffering.
So the patient might actually report feeling better right before the worst happens.
Exactly. The toe turns cold and black, and the patient reports, "The pain has stopped, doctor." That cessation of pain is often the diagnostic turning point signaling irreversible gangrene.
So the progression continuum is painful, suffering tissue progresses to a temporary absence of pain, which indicates irreversible death before the body walls it off.
Precisely. The source's clinical rule of thumb encapsulates this perfectly for a rapid assessment. Painful, pale, dry means arterial ulcer. The tissue is alive and suffering. Painless, black, cold means gangrene. The tissue is dead and unsalvageable without amputation or aggressive intervention.
Okay, now let's dive into the close calls, the scenarios where these conditions look deceptively similar. This is where the real deep dive insight comes from.
Let's take scenario 1. A small, dry, black eschar, a scab sitting over the tip of a toe. It looks like early dry gangrene, but the diagnostic clue is the physical check. Press the edge. If you press the periphery of that black area and the patient feels tenderness, or you see a faint red blush erythema appear, you are not dealing with full gangrene. You are dealing with an early arterial ulcer where the surface tissue has died, but the deep tissue and nerve supply beneath are still alive and reacting. This distinction means the limb may still be salvageable with revascularization.
That slight difference in sensation changes the entire treatment plan. What about scenario 2? The diabetic foot ulcer versus a gangrenous toe. They can both be infected, deep, and often black.
The clinical turning point here is the formation of a clear demarcation line. If the body can successfully wall off the dead necrotic tissue from the living tissue, that clean line, often red and inflamed, signals that the body has recognized the tissue is dead and is performing its own biological amputation. That demarcation line signals true, established gangrene, often requiring surgical intervention at or above that line. Without a demarcation line, it's just a deep necrotic but potentially still viable ulcer.
Okay, and the third confusing scenario, the classic diabetic patient with a blackened toe tip, but surprisingly, you can feel palpable peripheral pulses. We assume no pulses means arterial disease. So if the pulses are there, how can the tissue be ischemic?
This is a vital nuance.
Yeah.
If you can feel the dorsalis pedis or posterior tibial pulse strongly, but the toe is black, the problem is not a major vessel blockage macrovascular disease that causes classic gangrene. The problem is microangiopathy disease of the tiny arterioles and capillaries that feed the skin. The blood gets to the foot, but it can't get into the small vessels to feed the tissue. This results in an ischemic ulcer or necrosis due to small vessel disease, which may not respond to the large vessel bypass surgery that treats macrovascular gangrene. It dramatically changes the management and prognosis.
The progression continuum really outlines this journey for the listener's mind. Normal skin, moving to ischemia, then to an arterial ulcer, partial death and suffering, which deepens into a necrotic ulcer, and finally crossing that threshold of viability into dry gangrene and potentially wet gangrene.
The ulcer is the siren call. It's the warning sign. Understanding its precise classification is the only way to intervene early enough to prevent that final irreversible journey to tissue death and amputation.
We've completed the diagnostic journey. Now that we have a strong working diagnosis, venous, arterial, trophic, or malignant, we move to confirmation and management. Section 5 outlines the essential investigative checklist and the holistic principles of treatment.
Right. Investigation is all about confirming the underlying systemic driver. The first and easiest check on the list, and it's mandated for almost any chronic leg ulcer, is the blood sugar check. Why? Because diabetes mellitus is a three-pronged threat. It causes neuropathy, leading to trophic ulcers, it causes microangiopathy, and it causes macrovascular disease, leading to ischemic ulcers. Checking blood sugar is step 1.
Okay, and the most critical vascular study, especially when we suspect arterial or venous issues, is the Doppler study.
This non-invasive test is non-negotiable. It allows us to visualize blood flow and, most importantly, calculate the ankle brachial index, or ABI. For you listening, the ABI is a simple but powerful ratio. You compare the blood pressure measured at the ankle to the blood pressure measured in the arm at the brachial artery. Ideally, these pressures should be roughly equal, giving you an index near 1.0.
And what do the numbers tell us about the patient's prognosis?
If the ABI is between zero point 0.9 and 1.3, circulation is usually adequate. If the ABI drops below zero point 0.9, we start thinking about peripheral arterial disease, or PAD. Critically, the sources point out that an ABI of less than zero point 0.4 suggests critical limb ischemia. This low number means the ankle pressure is less than half the arm pressure, signaling a severe arterial blockage. It suggests a high likelihood of impending or established gangrene and demands urgent revascularization.
That low threshold immediately demands escalation. Now, for those chronic, non-healing ulcers, the ones that defy weeks of good targeted treatment, what is the mandatory next step?
Biopsy. It is absolutely mandatory for any ulcer that's been present for more than 3 months without healing, or for any ulcer that exhibits those suspicious signs like induration or an everted edge. We simply cannot risk mistaking a marginal carcinoma for chronic venous ulcer. The biopsy is the definitive way to rule out malignancy and guide aggressive treatment if cancer is confirmed.
And of course, given the high risk of infection, we need to know what we are fighting.
Correct. Puss culture and sensitivity is essential. Chronic ulcers are often polymicrobial, and standard empiric antibiotics may be ineffective. Getting a culture ensures we tailor the antibiotic treatment to the specific organism and its sensitivities. This is crucial for deep infections like osteomyelitis, which is why, finally, an X-ray is required to check for osteomyelitis bone infection, which is common when trophic or arterial ulcers penetrate deep, especially in diabetic feet. If the bone is infected, it requires far more aggressive long-term antibiotic therapy.
Okay, moving to the holistic management principles. The sources emphasize that successful treatment is not just cleaning the hole, it's a two-front war. You have to address both local symptoms and systemic causes.
On the local care front, the goals are pretty straightforward: cleaning, debridement, and appropriate dressing. Debridement is the process of removing all that dead necrotic tissue and slough. If you leave dead tissue in there, it just acts as the bacterial culture medium, and it physically blocks the growth of new, healthy granulation tissue. Debridement must be meticulous and tailored to the cause.
And what are the specialized local care requirements? They differ vastly based on the diagnosis, right?
They are entirely different. For venous ulcers, the primary local treatment is compression therapy. This involves applying high-pressure bandages or stockings to counteract the venous hypertension, reduce the edema, and allow the capillaries to exchange oxygen and nutrients more effectively. For trophic or neurogenic ulcers, the primary local treatment is pressure relief, offloading the foot. If the patient continues to walk on a pressure point, no amount of dressing will fix the wound. The continuous trauma will just perpetuate it.
Shifting to systemic care, this involves addressing the patient's entire lifestyle and medical history.
Yes. And this is where the patient's commitment becomes paramount. We must aggressively control diabetes, achieving tight glycemic control to limit neuropathy and microvascular damage. We have to correct anemia and malnutrition because healing requires robust nutritional building blocks. And in the case of arterial disease, the single most impactful systemic intervention is smoking cessation. Nicotine is a potent vasoconstrictor that accelerates PAD. Every cigarette pushes that arterial ulcer closer to gangrene. And finally, we have to treat the specific underlying cause, whether that's surgical correction for severe varicose veins or medical management of hypertension and hyperlipidemia for PAD.
And finally, the spectrum of surgical options. When does management escalate to the operating room?
Surgery can range from simple skin resurfacing all the way to amputation. For large, clean, chronic ulcers where the underlying cause is controlled, say a clean venous ulcer after compression therapy has worked, we often use split-thickness skin grafts or flap coverage to speed up closure and reduce the risk of infection. For venous issues, we might perform corrective surgery, like stripping or ablation of major varicose veins, to reduce the hypertension that caused the ulcer in the first place.
And the final resort, the moment of absolute failure.
Amputation. This is reserved almost exclusively for irreversible gangrenous arterial ulcers, especially when the patient presents with overwhelming sepsis from wet gangrene or when attempts at revascularization have failed and the limb is just not salvageable. The entire point of this deep dive, the history, the examination, the investigation, is to intervene long before amputation becomes the only viable option.
And we have arrived at the end of this incredibly dense deep dive. We started with the simple word ulcer, and we've learned how to read its complicated story. From taking the detailed history using the old carts and the 3 Ps to observing the critical differences in the edge. Is it sloping, punched out, undermined, or reverted?
And we mastered that crucial conceptual distinction between partial ischemia, the painful, suffering arterial ulcer, and total ischemia, the cold, painless black necrosis that defines irreversible gangrene. We learned that the difference between these two states is literally the difference between salvage and amputation.
Our clinical sources, which were developed to sharpen the diagnostic eye, left us with that evocative summation, reinforcing the need for keen observation. The ulcer tells a story if you learn to see, it will whisper its diagnosis. You need to learn the color, the depth, the texture, and the sensation of that wound to unlock its secrets.
And that leads to our final provocative thought, which is rooted firmly in that ischemic continuum. If the arterial ulcer is indeed the warning sign of PVD, and we know that progression to irreversible gangrene is a gradual process that only crosses that final threshold when perfusion ceases entirely, we have to ask, what untapped potential exists in perfecting the earliest, most non-invasive classification of ulcer types?
If we can use the edge trick and the precise quantification of the ABI to forecast that progression, to know that a patient's partial ischemia is about to become critical total ischemia, what new ways can we use that early clinical data to intervene before that demarcation line forms? How can we leverage this structured observation to change the patient's fate, moving beyond simple wound management to fundamentally preventing the irreversible progression to tissue death?
It reinforces the timeless value of clinical acumen and of paying absolute attention to the smallest details that the patient presents. Thank you for joining us on the deep dive.
We hope you walk away from this feeling well equipped to read the clinical story of the ulcer. Until next time.